And this can be with post-operative patients as an alternative to pendulums, which as we all know, are very difficult to perform. Michael didn't require that, but it's a mirror image of what's possible with this application. So Michael asked you to put your right hand on top. And so what we're wanting to do is the left arm, the involved arm, to go along for the ride. So the right arm will do all the work. And in the beginning, a person in pain, that little motion can be enough that it can either set the stage for a change or perpetuate what the person came with. This is a really helpful application prior to your manual efforts of passive range of motion on the table. So if you begin your patient with this, you get them on the table and their apprehension is diminished. You can go right to their in range and be effective with gaining motion. And then after you've done your manual work, you can have the patient come back to this, and the motion that you've gained, as I'll show you, can be utilized. So that's the first application. We want to accomplish the free spin, let the person gain trust of the tool, and then we progress accordingly. So then Mike will ask you to put your hand on the back side here, and then we can move down the kinetic chain and involve more of the distal motion so that the person just looks like a more natural movement. And then as he moves into the active assistive stage, and then we're going to progress without the support of the non-involved arm. Okay, Michael, you can take your right arm off. And so what I'll do now is ask him to progress upstairs. So Michael, go ahead and step forward here. And as you can see, we're simply just grading the elevation. So with the intent of reaching to full elevation eventually, we're just gradually accomplishing that. So now I'll ask Michael to just produce that motion on his own. And you can see that the tool supports the weight of the arm, so as he moves distally away from his body, then the tool continues to stay with him. And I'll show that again when we show the wall mount, how it compares to pulleys. We'll go up one more stair height. Okay. Now he can also, Michael, I'll have you put your left foot in front of your right, just like that. When we reach higher, we tend to use more of our body. And so this allows him to work his lower extremity in the act of supporting reaching. And as you can see, if there's a gradual restraint here, as I'm watching the details, we can look for substitutions. I can also work with my hands to guide the complexity of articulation. So a mobilization with movement where I don't have to hold the weight of the arm. We all look for that third hand, and this offers the freedom to both of us so that it can be a pure motion with the appropriate assist. So I can perform a depression of the humeral head, and I can perform an upward rotation of the scapula, whatever is necessary. And then if you recognize signs of fatiguing, then we simply work our way back down. So just do a couple strokes, Michael, all the way down. And then what I'll do is I'm going to walk you now through, as I worked with Michael, we recognized impairments on a motor level. So he was performing, the typical hiking of his shoulder, and we recognized his force couple wasn't keeping up with the elevation, and his scapula also wasn't supportive of rotation, so that scapulohumeral rhythm was in a disconnect. So Michael came with a multitude of joint restrictions, some imbalances of weakness and overpowered muscles, and so the typical manual skills can then blend with the support of the clinical tool, the upper extremity ranger. And so I'll walk you through that sequence now. And what I've highlighted essentially is the muscles of the rotator cuff and the serratus anterior and the lower trapezius. So muscles that we typically work with on an impaired level, we can activate, and then the good news is we can, with that activation, put it right into motion. And that's what helps the nervous system make sense of it and integrate it into the process of motor control.